Good afternoon. Welcome to our webinar today. This is our second in a series of Ask HMA Experts Anything. Our town hall style webinar is an opportunity to really address the issues that are of most concern to our colleagues and our clients and folks interested in these issues, and to take advantage of the experts that we have that can hopefully shine some light on what are a lot of big and very important questions that are being posed in the broader policy environment today. So we're thrilled that you've joined us, and thank you in advance, or I guess thank you in retrospective for all who submitted questions. We have a ton of questions that were submitted, more than we could possibly get through today, but some really great questions that I think will produce some fantastic insights. So I will briefly introduce our panelists and then we'll jump right into the questions. This will be recorded and of course shared with anybody who registered, and we will look for ways to answer all of the questions, even those that we don't get to today. So look forward to this dialogue. So let me introduce our panelists. And then I'll take down the slides and we'll just have a conversation. So let's start with Heidi Arthur. Heidi Arthur brings nearly 30 years of delivery system redesign experience with a focus on expanding access to integrated community-based health and human services for publicly financed populations. She specializes in best practice models that support recovery for children and youth with complex needs, as well as their families. And her projects support state and county leaders, behavioral health providers, and community-based organizations looking to optimize resources, advance service access, improve quality, and transform service delivery. Rachel Bembas is a behavioral health and population health analytics expert with a strong track record of improving health outcomes through data-driven quality improvement strategies and performance metrics. Rachel brings deep experience in leading cross-functional teams, developing innovative value-based care initiatives, and leveraging analytics to advance population health across Medicaid, Medicare, and commercial populations. Allie Franklin is a dynamic leader and licensed clinical social worker with a career spanning public, private, and nonprofit sectors, where she has led large-scale transformations in behavioral health and integrated care. Drawing on her frontline clinical roots and executive leadership roles, Allie brings a rare blend of systems thinking and practical insight to redesigning care delivery models that improve access, quality, and performance. Teresa Garate is a seasoned strategist and systems innovator with a 30-year track record of leading transformative change across public health, education, behavioral health, and government. Known for her ability to align diverse stakeholders and navigate complex organizational landscapes, she has driven growth and modernization efforts in both public service and national health systems. Monica Johnson is a nationally recognized leader in behavioral health policy with over 25 years of experience shaping and implementing transformative public sector initiatives at both the state and federal levels. From launching SAMHSA's 988 crisis response infrastructure to managing Georgia's statewide behavioral health system, Monica brings deep expertise in strategic planning, cross-agency collaboration, and large-scale system redesign. And Sarah Singleton is a trusted health policy strategist with more than 15 years experience shaping federal healthcare legislation. She's played pivotal roles in advancing bipartisan mental health legislation in her time at the U.S. Senate, and has worked closely with SAMHSA, NIH, and other HHS agencies when she was a Deputy Assistant Secretary for Legislation at HHS. Sarah is at Levitt Partners, which is an HMA company, and continues to advise healthcare organizations on navigating complex policy landscapes. So you can see we have a tremendous panel here of behavioral health experts and folks who are well suited to answer a set of questions. So Sarah, I introduced you last, and I think I will go to you first. Obviously, we are in a complex policy environment right now. Lots of other words you could use for complex, but certainly complex, lots of moving pieces. And so the first set of questions are, a little bit of crystal ball, like what's going on. But in your estimation, what are the most significant federal policy and funding changes that are either underway or sort of expected or anticipate that will affect behavioral health services across the states?
Thanks for the question, Jen. It's a big one, but I won't take up the whole webinar trying to answer it. If you've tuned into this, I think at some level you are thinking about the federal policy landscape right now, whether you're in a state, if you're a provider yourself, or if you're playing another role. I think two of the big trends and things to be watching first is that Congress right now is debating major legislation that will have impacts on a variety of kinds of programs, but I think most importantly for behavioral health, Medicaid. So the House of Representatives just passed legislation, and the Senate is now taking it up and working on it. And the House legislation makes a number of substantial changes to Medicaid. Most significantly, I think, for behavioral health are the work requirements that are put in place. And there was lots of back and forth, but what the House settled on was a policy that requires all states to have work requirements in place by December 31st. 2026. And there is an exception for people who are in substance abuse and mental health treatment. But we have found, based on past experience, that even if there are exceptions in place, it can be administratively very complex um, to show that you are accepted from requirement. So there are definitely implications for coverage loss for people who are in the behavioral health system. We know how important Medicaid is as a source of payment. At the same time, the safety net and backup when Medicaid payment isn't available has been lots of sources of discretionary funding that Congress appropriates and that grow out through SAMHSA and other mental health agencies into states. And those are at risk right now, too. We're in a tight budget environment. The president has put out sort of a high level budget, but without the typical detail we see. The budget is always a bit of a policy document. It's not something that Congress takes up wholesale and passes. Nonetheless, it shows the direction of where they want to go. And there's some big cuts imagined there in behavioral health services, among many other kinds of things. So it's a really important time for advocacy if you think that you'll be affected by those cuts to be talking about the impact of those things. And it's always the case that it's sort of a challenge to break through. There are so many different federal programs. Most staffers in Congress, I was one myself for many years, don't know all of those programs. So you really have a responsibility and a duty to kind of go in and educate and advocate for those programs. So there are probably some good things happening out in the field, and my colleagues who are experts here will talk about those. But from the federal sort of financing and funding landscape, it is kind of a precarious time with some changes to happen as all of these things move through. We're really at the midpoint in both the budget reconciliation process and really haven't even started the appropriations process for next year yet. So things can change, and so it's a good time to watch and be actively engaged on that.
That's great. Um, Rachel, maybe I'll go to you for the next question around kind of the likely impacts of proposed Medicaid cuts. Sarah referenced certainly many possible sources of cuts, but as you're thinking about Medicaid cuts in terms of restructuring behavioral health services, what do you see as the most likely impacts of what may come out of this process?
I'll get myself off mute. Hi. Yes, good question. I think in terms of some of the Medicaid cuts, it's really about um, understanding some of the strategies that are in place and what tools and opportunities you have to leverage. I think being able to manage what's happening federally really comes down to a lot of smart infrastructure. There are some states that are doing this well and trying to braid some of the funding streams. So Medicaid, federal grants, state general funds, other things like that. And they're trying to use those dollars to build some flexible systems that could adapt over time. I'm seeing a couple strong projects and innovations come out when states are investing in measurement strategies and quality improvement processes that are monitoring what's working and not just checking a box like a compliance or risk piece. That's also kind of positioning them well for value-based payment approaches, alternative payment models. And so being able to capitalize on other funding streams there as well. I've also seen this for kids and justice involved folks as well, really focusing on the coordination across systems being really a critical piece of that infrastructure. Continuing to break down silos between behavioral health, child welfare, juvenile justice, justice involved systems in schools. I don't think it's any secret that we can't really address complex needs with isolated solutions. And so we're starting to see a lot more innovation in this
Monica, additional thoughts there on sort of, given your role, prior, maybe two prior role at the state level, how do you see states adapting to these reductions, in terms of trying to maintain access and quality of care in the face of this?
Yeah, thank you for that. Rachel, I think did a good lead into this one as well. I think with apprehension, but then also with with opportunity, right? And so waiting to see what's going to be the final end game in terms of what happens to, for example, block grants, which states heavily rely on for to be able to do innovative, creative things for individuals that often do have serious persistent mental illness or SED youth, and being able to do innovation. And so I think that it becomes a let's see what happens, but then also an opportunity to prioritize some things that may have been kind of things that you do kind of automatic on kind of just this is what we do versus looking at opportunities to maybe pivot to some other things. And then to Rachel's point, an opportunity to really collaborate and try to leverage resources across entities. So I think those are some critical things that states, I believe, are grappling with right now.
Yeah, that makes sense. Um, Tere, maybe talk about partnerships, a question about partnerships between state agencies, managed care plans, and county systems. How can those types of partnerships strengthen resilience?
Yeah, that's a great question. And before I go there, I just a couple of things on the other question too is, states are going to be impacted differently by these Medicaid cuts depending on whether they were Medicaid expansion states or not. So it's important to remember that. I think it's also important to help people be proactively modeling out what happens to these cuts at different programs. So they're not going to affect everyone across the board in the same way. I think there's also work for payers to be thinking about, especially the payers that are in states where they're both offering commercial insurance and Medicaid plans, because there's opportunities to think about how to leverage that. I often say if or when the Medicaid cuts hit, the people who are accessing Medicaid are not going to go away. They're just going to continue to access treatment or services in different ways. And as a system of care, we're going to have to be ready to respond to that. So that leads nicely into the partnerships question, because I do think that at the state, county, and city level, there are some controls that those entities have that are outside of Medicaid funding. There are opioid abatement funds, there are local county 708 board funds, there are individual investments. So I think the sooner that those entities can start talking to each other and leveraging what they currently have, the better prepared they will be for the future. We do a lot of work across the country where we see siloed systems everywhere. So this is not kind of a negative soundbite, it's actually a soundbite around opportunity. If there was ever a time to start breaking down those silos, it is right now, and thinking about, if we are trying to address multiple municipalities' needs within a large county, what does each of those municipalities have at the table, and how can we start thinking about combining and braiding funding, as well as maybe breaking down some of the regulatory challenges that exist to use that funding, so that in the future it will be able to be streamlined and easily pushed down to the people that we're trying to serve.
Maybe hold the mic for a sec. Click down a level into addiction and behavioral health interventions around substance use disorder. So how does that sort of play out with those particular programs? If there is an anticipated reduction, obviously I think that's continues to be an important policy priority, but if there are funding cuts, how would those reductions impact services?
Yeah, I'm gonna start it and then probably ask Monica to jump in too, since she was just at SAMHSA. So I know everyone is, not just the cuts, but the changes through to the agency and what's happening, I think is also a looming kind of thing to think about, right? So not just the cuts, but the people who were there, who were doing out the best practices, and this is what we're doing. some of them are no longer there. And so who is setting the table around what is the vision in the future? So that's really important. I also think that I want to make sure, that we stress that when we think about behavioral health, it's mental illness, severe mental illness, and substance use, but also process addictions, not just substance use, but all the addictions and how they're going to be impacted. And the way that you get to those process addictions is usually through a mental health diagnosis, but we often forget about that subset. So just kind of thinking about addictions in general. I think for substance use specifically, the opioid abatement dollars that are being pushed down to the states through the various lawsuits, I think are an opportunity. I think there's whoever is listening to this town hall thinking about your local communities and how those opioid abatement dollars are being pushed out and what are the strategic plans that are happening and how are you measuring that is really important, because you want to be able to show that those dollars are really addressing what the intent of it was. We have historically seen, class action lawsuits and things like this, the funding go to other things outside of what they were designed for. So that's really important. I also think as we help clients and partners figure out what the local needs are in their communities around opioid overdoses, which are going down and really pushing into harm reduction, that is going to become even more important. So prevention before we get down a path where, obviously addiction and substance use and people living in recovery, it's a journey, it's a long-term recovery, but also thinking about prevention and education early on so that we're addressing people before they get to that point where they're going to need even more intensive supports. I don't know if you want to push it over maybe to Monica or.
Yeah, Monica, please jump in.
Oh, I want to think about it. Yeah, I do want to jump in. I want to think about it from the user end and kind of from a clinical perspective and around maybe opportunity between these spaces. So when we talk about looking at ways to leverage and be more less siloed, I think this is a point of intersection where some systems, you follow the money, and some systems are very intentionally separated, like substance use and mental health, when we know that many people present to the system with co-occurring needs for mental health and substance use. And so while we're maybe in this moment of thinking about how to be better collaborators and trying to figure, while we're reading some tea leaves, but figuring out how to decrease some of these silos, we have to start to think about our systems in a way that is more coordinated. I think about being just from some previous clinical experience and thinking about, I used to sit on a mortality review and thinking about individuals that would die by suicide that would be misdiagnosed with not having some addiction things addressed. And so the mental health things would be addressed, but the addiction things were not being addressed. And so while we're in this moment of trying to think about what the possibilities could be, how do we be less siloed, I think this is a clear opportunity for individuals to be treated better. And when they are presenting with multiple needs in the system, to think about how it is responding to individuals when they show up needing support or treatment for both a substance use disorder or process addictions or mental health. So I just wanted to add that to the tail end of what Terry was speaking about.
I actually think this flows really well into talking about integration into primary care as well. That when we talk about breaking down silos and we talk about integration, it also involves saying, let's take a look at where people show up for care. And if we have providers who are struggling, if there are potential cuts or changes to federal funding and those kind of things, we know that people will still need that care. I think that's a great point that you made, Terry, around, people don't disappear, right? And so are people able to get care in primary care? Are we thinking around routine screening? And what happens if a person has a screen that shows that they may have some vulnerabilities or that they may have some needs in the behavioral health space? Again, whether that's mental health or substance use or co-occurring in both. And so how do we bolster the support systems that are available in emergency departments and in primary care to be able to be responsive to the needs that may be walking in the door, maybe talking about it more in primary care or in emergency department if people are struggling to get access in the behavioral health system?
And is that I guess the answer is always going to be both, but how much of that is sort of how we're paying for these things in value-based care kind of ways, and how much of this is clinical coordination and, building kind of data infrastructure there.
I think it's really both is the exact answer, right? There's the piece around how do we incentivize kind of pay for reporting and pay for action, and then move into pay for outcomes when we think around value-based payment. But the other piece is really winning hearts and minds in the clinical world, that sometimes when we talk with primary care providers, they're reluctant to ask the question because they don't know what to do if a person has a positive screen. I've talked to providers who say, I'd rather not ask the question where I identify that there may be vulnerability around suicidal ideation, around substance use disorder, because I'm not sure what to do when that person says, yes, I'm struggling with those issues. And so how do we as systems begin to build those linkages so that the providers feel more comfortable asking the question, and then feel confident around what are those systems of care that are there to support someone who does have those vulnerabilities that are identified, regardless of the setting. I think one of the key things when we look at this landscape right now is to really lean into this idea around no wrong door. And that fits when we're thinking around those clinical linkages, but also in the payer linkages, and in those, how does a community work together to support people who are in need?
And Heidi, let me bring you into that conversation, talking about community, those in need, and certainly there's a lot of underserved populations there. And so, what kind of approaches can our systems take to close these gaps and sort of improve the follow-up care and, kind of fill in those gaps that we know exist, even if we improve our incentives to better coordinate, we know there's still some gaps, certainly for some populations.
Absolutely. I feel like this point in time is potentially a real opportunity. There might be some crises around lost funding.
Oops. See if her audio comes back. I
Can you
know
hear
that
me
was
now?
going to be. There you go. I was going to say, I know
Oh,
you were
sorry.
making a good point, so go
Yeah.
ahead.
I was just going to say that I think there could be a real opportunity in the crisis that many organizations and systems are facing, because at the time that there might be disruptions to traditional funding sources and delivery methodologies, there's also understanding of the value of peer support, the value of community health workforce, the value of really connecting with local community organizations that are serving the same populations to co-locate services, really do some of that, to the earlier points raised, just local stigma reduction, prevention education, and creating some real streamlined approaches to warm handoffs and community-owned solutions that are human-centered and really have the voice of lived experience at the table. And so I think in our work, we often see some of the most exciting work when local communities hold responsibility and share governance across multiple systems to solution around really the highest risk populations, but getting upstream to avoid those high risk populations from occurring, right? Get ahead of the problem. So there's some just really wonderful examples of communities pulling together. I think we saw it a lot in COVID, and we're going to see it more going forward, where they do need to blend and braid funding, and it does require, sort of an agreed understanding that we are going to share models for real cross system and multi-sectoral collaboration.
Yeah, sort of.
And if I can add maybe
Please.
just one like practical maybe summation, right? And like one practical takeaway that I think organizations can do is really looking at their like what's bringing in their costs, because I think on a spectrum too, like there are dollars that are not at risk, and then there are some that are, right? So the more federal we go, the more those dollars become at risk, right? But stuff that's coming from the state, maybe somewhat at less risk based on like the state appropriations, things like that, block grants, opioid dollars, right? Like those things are less at risk. So kind of understanding like where their funding is coming from. Then I think to really Heidi's point is then identify the high impact, low cost interventions that are really bringing in your return, right? So crisis stabilization, peer support, community-based outreach, all of those things. I think seeing how that funding is then braided across to see how you're able to support care continuity is going to be really important. And then also, where are your investments, right? So where are you, I mean, you know, where are programs aligning with mission? Where are you able to put some of those devoted resources in things like quality infrastructure? Because now we're able to kind of see how you're starting to develop your value proposition for BBP and alternative payments, right? And so a good positioning exercise, I think right now is probably a good, you know, due diligence piece for organizations to be doing right now in this uncertain world.
Yeah, that's great advice. Um, well, let's see. You mentioned crisis stabilization. So Monica, I'll come back to you. Um, you know, federal funding aside, obviously the 988 system is a combination of funds. So how do you see the infrastructure evolving over the next, 3 to 5 years for crisis support services?
So I think in spite of like concerns about funding and those things that are legit things to be concerned about, that the system will continue to evolve. It may change at the pace in which it evolves, but the system will continue to do what it's doing. And what I mean by that is prior to the implementation of 988 almost 3 years ago, crisis services were still being built across the country. People were still receiving crisis care, crisis stabilization, community programs were being developed. Mobile crisis teams were out there, co-responder models were out there, peer crisis respite centers existed. And the crisis contact centers existed. So I think that I feel that the work will continue. The work won't have a choice but to continue, because people are going to still appear to in our communities and show up and need help when they're experiencing a crisis. So I think the work will continue. The only thing, like I said, that I think may be impacted is the pace. I am encouraged by the amount of states that have already stepped up via finding other ways to help support the expansion of their crisis systems, rather that's through a local appropriation or other mechanisms that are outside of federal grants and federal support in that way. And I hope to see that continue. I think that there is bipartisan support around the initial promise of 988. And I think that I see that continuing.
There's so many questions. I'm scrolling around here. So maybe let's talk about kind of incentives. We've talked about the kind of opportunity here. And to the point you just made, these things aren't going away, right? We need to continue. We know that the systems will continue to exist, and we know that there's an opportunity for innovation. So maybe talk a little bit about some delivery system strategies here. So Allie, how are we talked about integrating care. We talked about, better coordinating care. How are we incentivizing kind of our traditional primary care providers to either hire or partner or integrate behavioral health staff into their practices so that we can kind of close some of those gaps for some patients?
So it's a great point, because again, we have to think around that no wrong door. Where do people come in the door, and how do we help get people care so that they don't end up needing to go to the emergency department or in a place where law enforcement needs to get involved? When we see some of the incentives that are coming into play, it's a couple of things. One, you think around collaborative care models and thinking around reimbursement for collaborative care codes as a key strategy to say, by administering a PHQ-9 or looking at a screening tool, and what does that look like? Is that now a billable service, or agencies able to do that? But beyond that, it's also around how do we remove barriers around creating a more coordinated system of care? What do referral pathways look like? Is there visibility in the system between primary care and behavioral health? Are there community information exchanges or health information exchanges? You think about referral pathways and some of those pieces. So incentivizing people instantly think dollars in some of those ways, but I also think it's around how do we remove barriers? How do we make it easier to do the right thing? And another piece is how do we help providers know that I made a referral to someone, did they actually get there? Closed loop referral systems and being able to make visible to the provider that a person is actually getting connected to those care pieces. I made a referral to specialty behavioral health. Did they ever get there? Were they able to do something? What sort of integration exists in that system? The other thing I think is helping providers know you don't have to be all things to all people, that you can do that through partnerships. You can do that through a primary care clinic working together with an existing behavioral health community provider and saying, could we think about co-location? Could we think about e-consults or telehealth consults? That it doesn't have to be one primary care provider suddenly hires a therapist and a peer support specialist and someone who knows how to bill about all those pieces. It can be around saying, we agree on a shared value that this is important and that humans are holistic and they have behavioral health needs as long as alongside their physical health needs, but that you don't have to singly be responsible for all of it. And so by partnering together with those other entities, then they bring in their expertise, including how to bill and how to do those things, but they bring it in a place that removes barriers for people seeking the care, which are our clients. So they're more likely to actually get what they need because they can see someone right here in the office.
Can I add something, Jennifer?
Please do, yeah.
So I think we had some questions about CCBHC, and so Allie's points made me think about the different models that support integration. CCBHC is definitely one of them, and we at HMA help lots of states and clients develop that. I think, you know, people are worried about whether those are going to go away, what's going to happen, but the model of CCBHC is a really effective way to do what Allie's talking about, is integrating care and creating partnerships. I think the other thing that is important to think about when you're thinking about integrating care, it's also leveraging how do you incentivize that. So we have clients where we have helped create integrated practice alliances or things where, you know, there is an incentive a lot of times in behavioral health and in primary care and just in healthcare in general. We do not incentivize that. You know, it's like if it's fee for service, you're not going to get paid if somebody's not there. But the more we think about helping population health achievement, right, reduction and really health outcomes, then the more we incentivize that collaboration, not competition, or, you know, collaboration versus competition. And when you think about the SUD space, that's another layer because there's so many co-occurring, but also thinking about how the individuals, whether that's their primary or their secondary diagnosis in that space, are cared for through an ecosystem of care throughout the community. So a couple of things around that integration and incentivizing collaboration.
Sarah, she mentioned sort of potential funding cuts. I mean, how stable is this funding for the CCBHC model? What is your sense of kind of where that sits on the spectrum of bipartisan to partisan priority?
Yeah, I was working in Congress on the authorizing committee. This legislation went through in 2014. And it was originally a bigger bill and it was mandatory. And they found, like you often do with legislation that actually makes it through the process, they found a way to make it a bipartisan bill and to make it an option. And I think they really solved a lot of the issues with it. And we've seen obviously incredible growth of the model since then. So I think the piece that, ties into the payment model once you are a CCBHC, I view as pretty stable. It is popular. It is in red and blue states. This is an issue, mental health and substance abuse, that has political resonance on both sides of the aisle and generally has not been politicized. So I think that part's stable. The new funding that, SAMHSA has given out at various times to, create and establish new CCBHCs. I think that it's hard to say. It's not that itself is vulnerable alone, but in the budget context that we're in, it is vulnerable. So there might be a pause or a hiatus for a time on that new grant funding to be able to establish the CCBHCs. So if you are not yet If you haven't met the criteria and you're looking to get there, I would go to the strategies that other colleagues on the phone have talked about here, being creative about other sources of funding to get there. But I think once you're in the program, we're going to continue it. People want to see how it can keep growing and doing what it is. So a bit risky, but also in part safe, I think.
Yeah, great. A lot of what we're talking about, I think, is, relying upon data and systems and technology. So maybe there's a couple questions related to those topics. Heidi, talk about perhaps data collection and analysis around social determinants of health and how, if we're building these systems, improving these systems to be able to coordinate, we also want to be able to pull in other data that's sort of important to these, not only diagnosis, but certainly management. So, what opportunities are there right now, or what are you seeing that's kind of promising that could help, streamline and better coordinate and also collect important pieces of information that lie outside the system?
Yeah, that's a great question. And I think that, we're heartened that so far the waivers that have allowed Medicaid to include social determinants of health have been retained. And there are a number of states that have taken advantage of that to actually use Medicaid to support infrastructure development and actual payment for food assistance, as well as housing supports and transportation, et cetera. And the systems that are being developed to facilitate that screening, that navigation, that sort of identification of those unmet social health needs really does create an exciting opportunity to look at where there are gaps within the local system of care, where those services just aren't available. And so costs related to sort of those health-related social needs are driving greater utilization of more costly systems. So I think that, systems that haven't benefited from the infrastructure development to support that screening can just do those things, right? It's not hard to implement. And we frequently work with organizations that have used a standardized tool. They've begun to identify those social risks for their population and make referrals locally. And what they're finding is that they're creating a relationship with their populations that is more holistic and more responsive to all the things a person needs, that drives stress, that creates burden, that really does overwhelm people and create some of the crises that we often see in the behavioral health end, but can be prevented by leveraging local resources. So I would say that the data collection is really important because it helps communities hold responsibility and bring solutions for the needs of their population. And it also creates the opportunity to be responsive to people's existing needs. And that earlier point, I think it was Allie that said that, physicians will express concern about asking questions that they're not sure they can address. I think sometimes people feel that way about social health. Like, I don't want to ask about housing instability or food insecurity because I'm not sure what I'm supposed to do about it. And I think that when we're treating somebody for a sort of second order condition, when their primary need is that they're hungry and they don't have a place to live, we're probably missing the boat and really being responsive to what that person and their family and their community really, really needs. So I would encourage asking the questions, collecting the information, and then bringing the information that's discovered to local systems for local problem solving and solutioning.
And if I can add to what Heidi's talking about here, because this is also a topic I care deeply about. And I think we're at the point where collecting SDOH data is no longer optional, but it's really foundational to understanding disparities and improving outcomes in behavioral health. I think a lot of systems are trying to collect the data, but the challenge is not just having the information, it's making it meaningful and acting on it. Because like Heidi said, if you have somebody whose primary need is, eating and having a place to sleep, that absolutely needs to be addressed. What I've seen, and I think what we see often, is that this gets tacked on as an additional task or an extra task, like another form or part of the intake to complete. And it's not really integrated into clinical workflows. If it's not built into how we engage with people, then it's not going to be high quality. And more importantly, I don't think it's going to be. I think the first step is making SDOH screenings a routine part of care. It has to be embedded into your EHR and your systems. It has to be paired with clear next steps, because if you identify a need, there has to be a here's what happens next, right? Here's who the referral goes to, or here's what next needs to get triggered. What do we do when somebody has a positive screen for housing, instability, or transportation? We can't just stop at the identification of, okay, well, thank you for letting us know, right? There has to be like that next step. And I think that this is where a lot of systems and organizations are getting stuck. I think once we're collecting data, the next piece is stratifying it and using it and looking at it. And this is where really some of the equity pieces come into play and understanding the disparities. You have to look at differences in outcomes based on, race, ethnicity, location, SDOH needs, payer, disability status, and then ask, are there patterns that are emerging that we need to address? Are certain communities waiting longer to get services? Are they dropping out of care faster? Are they getting fewer follow-up connections? I think that's where actually data starts to drive action and starts to become more, prescriptive or action-based. Because if we only build that analysis capacity at one level, then it kind of still, there's a disconnect, right? We need to build that capacity at multiple levels, at the provider and at the system level. I think states have a role that they can play here as well in terms of standardizing SDOH elements that are being collected. So for example, Heidi mentioned, certain standardized SDOH tools. So aligning with something like the Prepare or AAFP's screener, or even kind of tuning into what the Gravity Project is doing right now around a lot of their operationalization and standardized definitions. And thinking about HIT investments, technical assistance, centralized dashboards and disseminable data, that way it's not just left up to the community-based organizations to figure it out on their own. I think the short version here is, collect the data, integrate the data, use the data, stratify it, and then act on it, because it's only as powerful as the decision it informs. If we don't start to shift resources or redesign care, we're, like Heidi said, we're missing the boat.
And then I have to jump on here because Rachel made some really good points. And so once you do all those things that Rachel just said, then to me, it becomes about training of the workforce to be able to appropriately do the right types of intervention and support. So when I think about care around behavioral health, I always think about it in terms of support and treatment, because I am thinking about those social components that Rachel just described. And so when that information is collected, if I'm a case manager or, a navigator, community resource, whatever the title may be, and I don't have the prioritization of my work is not there, it is an afterthought, then you have these workforce challenges that don't allow for some pretty significant clinical outcomes to even take place. So we often will assume that when an individual or a family doesn't show up for follow-up appointments, it's because they're not compliant. It's because they didn't do something they were supposed to do. Versus if you had a holistic picture, because you're collecting the data like Rachel just outlined, you'd understand maybe more about there's some housing instability here, and maybe they are trying to figure that out right now, and that is a priority, and that's why they didn't come to this clinical appointment per se. So it is so important to have that whole picture, that data, but then the prioritization and then the training and the support for the workers who are charged with doing that level of work, which often bills at a different rate, a lower rate, is often, paid the individual less. But those are the most complex points of intersection that if you don't address, that person then shows up in the crisis part of the system. And it's a cycle on repeat. So I just think this part of the conversation is so critical. And I'm not going to keep us here, but it's so important.
Well, let's stay on workforce. Sorry, somebody was about to jump in. I want to stay on workforce for a minute. Like, is this part of, does this help address workforce shortages by identifying these roles? Or does that make it harder because, those are trickier roles to fill?
I can start. I think it could be both. Like, I think that for me, it feels like when people are not satisfied with the work that they're doing, or they're not feeling like there's a return on investment on their work, or they feel, like they're not making headway, you often can go back to looking at how that worker is being supported. And so people often leave the field or may leave an entity because they don't feel like what they're doing has value because it's not being prioritized. So I think it could be both things depending upon what the exact issue is. I think if you train and support people and pay them accordingly, that does a lot to help with retention in workforce.
Terry, you were going to make a comment, and then Allie.
I think Allie, go ahead. I think Allie was gonna go ahead.
So Monica, I completely agree with you that if we can show that people will get better as a result of the care, that's what got me into the field, right? That's what gets a lot of people, we didn't get into the field so we could do a lot of paperwork and bill correctly and code correctly. Those are the things you have to do, but you did it because you wanted to help people get better as a result. But I also think that, to answer your question, Jen, around thinking about does this help or hinder from the workforce standpoint, it does both, right? So on one hand, it's really around how do we create meaningful pathways career pathways for people so that you can be doing this work without necessarily having to go and get a 4-year degree plus then, independent licensure and those kind of things. And so how do we think around bringing in additional levels of support to our workforce array, right? So these are your community health workers, these are peer support specialists, these are behavioral health technicians and people at the bachelor's level. So really beginning to build this pathway, this stair-step way that gets people excited and interested in doing the care, that shows that by doing these things, people get better as a result of being able to get them connected to things. Some of the most meaningful things we can do for people is get them connected to some of these social determinants of health and health-related social need pieces that make the most difference. But the other thing is to say that as we help get community health workers involved, as we help get people at the bachelor's level involved in this work, we can actually begin to help them earn while they learn. If someone wants to be working towards independent licensure and those kind of things, they can be working in the field right now and doing important things. The other thing that it does, and I think administrative burden is an important thing when we start talking about workload, is that if I'm sitting there in an office trying to make sure that I'm doing all the things that I'm supposed to do from an assessment standpoint, I'm asking all the right questions, doing my documentation, I'm checking all the boxes, making sure I get my Z codes in for, all of those pieces that I'm supposed to do, it may feel like that's a one more thing. Whereas if we can widen the definition of who is a care team, then we can actually say to the provider, let's have you do the things that only you can do, and let's widen the team, make sure your client is getting what they need and their needs are being assessed and addressed, but that you aren't personally responsible for everything that's going to happen in this case. And by bringing in a wider definition of team, we actually make the job seem less impossible. And so therefore people are less likely to burn out. They're less likely to leave the field prematurely. At the same time, we're building this pipeline of people who are saying, I'm really excited about continuing on and taking the next step and being at a provider level.
There's a question that came in that kind of, I think you're getting to, and the question is about clinical training, clinician education. If they're not getting this education early on, are they going to, how are they going to be able to kind of operate in a more integrated workforce? But I think what you're saying is, doesn't necessarily have to be them that the clinician that does all of these things if we're creating teams in the right way, which doesn't mean that we shouldn't improve clinical education, but it means, we're not just asking clinicians to do more. We're saying, let's create supports that allow us to do more.
I think also, the clinical practice and functioning to the top of your licensure is a big issue, and how states license individuals in not just behavioral health, but in the physical health as well, right? So the behavioral health care workforce shortage is a crisis. So is the physical health, right? We don't have enough primary care physicians to do those screenings to figure this out, right? People are going into specialty treatment, and the medical field is one group of individuals that are meeting the needs, right? We see the large number of people working in the behavioral health workforce are the direct service individuals. And until we think about rate reimbursement reform and also breaking down the barriers between states around licensure, and being able to pay people at the right level and also invest into the pipeline. Those are kind of the three things, right? Pipeline, retention, licensure, and also maximizing on those individuals that you have on a team, right? If it's the licensed social worker, the one that's trying to get the prior authorization instead of providing the services, that's not using them to the best of their knowledge. So it's, or the best of their capacity. So it's a complex issue. And I think when you think about workforce, you also have to think about the investments that are being made outside of the behavioral health space around recruitment. You know, if you look at other models like Grow Your Own and teachers, thinking about how do we grow our own in this space? How do we leverage peers, people living with lived experience, and help individual entities, meaning counties or cities or states, break down the barrier so those individuals can give back and enter the workforce and stay and grow through the ladder of career development.
And we are seeing states that are doing innovative things to break down, to make it not so difficult, right? If you think about, in order to get a 4-year degree, and then you need 3,000 hours or 4,000 hours of supervised practice before you can be billable to private insurance, right? So we look at states that are doing apprenticeship programs, that are doing cohort supports around, you know, how do you take unlicensed team members and help them think through what's a career ladder for them? And how do they build this supportive cohort around adding in those trainings so that it's not wait till you get the job and then suddenly now you need to learn all these things. It's really learn as you learn and learn as you go, so that we're really building this strong foundation of a workforce, but also this value that says providing these other supports are just as important to the care plan as the medication that someone might be prescribed, as the evidence-based treatment protocol that they're going through, that so is thinking about social determinants of health, so is thinking about those other connected supports.
I think also to speak to the question around, like, you know, isn't some of this stuff foundational, right? Like, we know how to do these things. And I think, like, yes, it definitely is foundational. It may seem tangential to things like policy and system change that have been insanely slow to evolve, right? So we are also in a point where we're trying to pivot fast in a system that does not do that, right? And so there's lots of parts that are broken. However, I think, you know, even if we built the best screening tools, have the best care coordination models, have the best robust data systems, if the workforce isn't trained to do things like ask sensitive questions and doesn't know what to do when somebody screens positive, like for our SDOH example, the model will break down at point of care. I still think that we're playing catch up also from like decades of clinical training that never really centered on behavioral health, trauma-informed care, or interpersonal collaboration. This is all really like new. I think behavioral health really kind of became center stage through COVID, right? And where it was like, okay, well, now we see what happens when people can't socially interact, or, you know, children are no longer going to school, and a portion of them now lost 2 meals a day that were guaranteed for them, right? Like, we see these things start to emerge. And if we want integration to succeed, whether that's in behavioral health with primary care or addressing social needs in a clinical setting, I think we have to not just invest in tools and workflows, but in people. And I do think that we have to rethink curricula, strength and supervision, supporting continuing education that aligns with this. And so while, you know, maybe beyond the scope of, maybe this is another HMA expert panel conversation, right? But I do think it is important.
Yeah, it's a great point. We're closing in on the last couple of minutes here, and there was a bunch of questions around kind of innovation and opportunities. And so maybe I thought if each one of you could take, I don't think you each have a full minute, but kind of what innovations, it could be technological, it could be human-centered, whatever. What are you seeing in your work that's kind of showing promise? I know it's easy to look around and see all the places where things are broken, but what is kind of really showing promise that kind of indicates that some good things are happening, that we're innovating in the right places? Whoever wants to go first.
Happy to jump in and say that I'm really excited about youth-led service planning and design, kids who understand mental health and behavioral health and recovery in ways that so far exceed the knowledge and understanding of kids when I was younger. Really hearing what their ideas are that are so recovery grounded and rooted in really authentic engagement with one another, with their school staff, their families. Just some really exciting ideas that they have about promoting well-being in their local communities. That's an area of innovation that I feel like behavioral health providers could learn a lot from in terms of really getting creative and getting scrappy about how to do prevention and stigma reduction and early engagement and identification of high-risk kids by engaging with kids and young people to hear what their ideas are.
That is exciting, and I would think applicable to other age groups as well, right? Figuring out the peer piece.
Absolutely. I'm excited about, and I saw a little bit of this kind of at the end of last year, and but is bringing commercial insurance to the table to begin to talk about how does commercial insurance understand how to pay for some of these services we've just been talking about, the outside of the traditional independently licensed person or the PhD psychologist or the physician or the mid-level nurse practitioner or PA. But how do commercial insurances come and learn how to pay for a peer support specialist, an unlicensed provider, a bachelor's level, someone who's doing outreach work in the community? And so it's not easy. It's way more than just one legislation and with the stroke of a pen. However, now it's easy. It requires some technical assistance. It requires support on both sides of it. But I'm excited to see that we're bringing commercial insurance to the table as a partner and a payer partner.
And I know there were questions around mental health parity that we didn't get to. One of our colleagues participated in a webinar, and I think, Terry, you were on that as well. Rachel, both of you were on that. So we could maybe share that link because I know that went into details on the mental health parity. Terry?
Monica, did you want to go? You were ready to go? Or...
Go ahead. Go ahead.
I think an innovation that probably cuts across a lot of things is leveraging AI and, which I know is a little bit for many people scary, but we've seen with clients and some of our work that we're doing around administrative burden for clinical notes and really facilitating it has really impacted workforce. So leveraging that for those things, but also predictive analytics to find people before risk, so high need populations. I think payers are well positioned to do that with the number of data and information that they have, but so are providers. And we at HMA have clients that we're helping to do that. So I think those are two areas, and I'll stop. There could be a lot more, but
Those are great.
I'm going to be probably not that surprising. I'm still going with the innovative work that is happening as a result of 988. And I'm going to specifically hone in on diversionary work. So work that is moving individuals from having to have police responses when they can get a more appropriate behavioral health response. So looking at communities that are working with, so 988 centers working with local 911 centers to figure out how to have more collaboration and to have better responses. There is innovative things coming out of that. May take some time to see, but I think that remains really important and innovative to me.
Absolutely.
And I think
Rachel?
maybe Monica, like you, this is not gonna, I think, blow anyone's socks off and might not even be considered innovative, but I think it's really crucial and maybe best practice and probably innovative for a lot of behavioral health providers. And that's leveraging their data to work better for them. And a lot of behavioral health providers are working with legacy systems that were never built for any type of integrated outcome-based care measurement reporting that they're being asked to deliver like today. And so I think that kind of puts them at this crossroads of they feel probably, that there's this momentous task in front of them that how do they get from like having nothing to some Cadillac system? You don't even need to do that, right? Like working with the data you have now to be more measurement based than data informed is where I'm doing a lot of work with providers, right? And so there are ways, like even Teresa said, with like leveraging AI or kind of working on some automated reporting structures that you have with your data today that you can do today to start to move in that direction. I think a lot of providers are starting to think differently about that and more innovatively and kind of testing things like value-based pilots, other programmatic deliverables, things like that they can use and collect data on today to kind of shift some of that improvement effort and quality outcome.
Yeah. So that's kind of, I feel like, a theme that we've heard today: being scrappy, being innovative with what you have, finding ways to be resourceful, recognizing that in an environment that was already resource strapped, maybe more resource strapped in the near future. And so, but great to, I think, land in a place of seeing good things happening. And it sometimes feels like the sky's falling, but there's a lot of really great stuff that can come in an environment where people have to be creative. So I really appreciate all of you and your contributions. Clearly, there's more to be discussed, and we will discuss in other environments. But hopefully, the questions and the insights today provided some value to folks. So thanks for joining, and we look forward to seeing you all again. Thanks.
Thank you.